I'm Sally Greenberg, a medical oncologist at Western Health, for those who don't know me. I'm passionate about quality of life in our patients and also about service provision and how we can improve the quality of care we provide and the safety of care we provide, and communication as well. So I'll rush through the first few slides because I think they're all familiar, or will be familiar topics to everyone here. But we all know that cancer can occur in anyone. So we have some good, some bad, some famous and some ugly. We know that the incidence of cancer is increasing dramatically in Australia and across the developed world. The prevalence is increasing as well due to our improved treatments and our increasing 5-year survival. We know that cancer patients develop symptoms both due to their cancer and due to the treatments that we give them. We know anecdotally and from the literature that cancer patients and their carers lack confidence in managing these symptoms. And at Western Health, we had no dedicated model of care or pathway for early chemotherapy symptom review. We had a look at the Australian and international literature and found nothing that we could really utilise well in our institution. These are going. Okay. So what happens when you get sick? The middle patient's starting to feel sick. She can just get sicker at home. And our patients frequently do that at the West. There is a population there with poor health literacy, large bulk billing or poor access to GPs. You can go to a GP if you can get in. Some of the GPs are absolutely fabulous and some aren't. With the ambulatory provision of cancer-based care, we know that more patients are in the community and more patients are accessing these GPs, and as the treatments change, the known toxicity and what to do about the toxicities is reducing. You can present to the emergency department. We have a great emergency department. I have a lot of faith in what they do there. However, it's a really busy place and not always best for many of our cancer patients or their presenting complaint. Or you can present to the chemotherapy day unit on the day of treatment. And we did do a local audit at Western Health and found that just under 10% of our patients were requiring medical review on the day of treatment. We don't have a model of seeing an oncologist on the day of treatment. And if I come to the emergency data again, we did an audit, a 6-month audit in 2012 at our institution, and found that of the 592 patients who were presenting to the CDU for chemotherapy, 41% were attending the emergency department during the same period. And of those who attended, 36% were seen and sent directly home from the emergency department. And of those admitted, 20% were discharged within 24 hours, and the median length of stay was 3 days. We thought we could target a lot of these patients better in our chemotherapy day ward and avoid emergency altogether. We thought if we can identify and manage symptoms earlier, we can improve the quality of life and symptom management for our patients, and that's fundamentally the reason for this clinic. But we also thought we could reduce emergency presentations and improve the efficiency of our chemotherapy day unit. And I guess that by doing that, or having that as one of our aims, it allowed us to access a chemotherapy redesign grant to look at efficiency in the chemotherapy day units. So we decided to use this grant to set up a symptom and urgent review clinic. We had an advisory group with members of all key teams, including surgery, emergency, pathology, radiology, bed access, nursing and consumer representation. We set clear pathway developments and a triage system and a prospective database. We thought the best place for this clinic was to be located in the chemotherapy day unit itself, but in its own separate room. We staffed the clinic by experienced oncology nurses, and importantly, these oncology nurses provided all the pre-chemotherapy education so that they could educate about this clinic at the same time and could encourage phone calls early at symptom development. We adapted a triage system from the UK and had clear, agreed-to patient referral pathways. We developed this clinic as a phone or walk-in service where during office hours patients could call the nurse in the clinic whenever they needed. This was encouraged, although drop-in service was available as well. We preferred patients to call first so that the timing and flow of the clinic could be maintained. The nurse in the clinic had ability to review, treat, and if required, directly admit patients to the ward from the CERC clinic. Our chemotherapy day unit does have medical cover with an unaccredited oncology registrar working there, but also I'd say the culture of the Western Health means that there is access to other people to answer questions or help as required. And importantly, and we didn't really realise how importantly at the time, but we did collect detailed data collection and have ethics, prospective ethics approval for data collection on all the patients that we see during this clinic. And this has allowed amazing quality assurance projects through the Western Health and allowed us to sustain this clinic with over time. So since we commenced our CERC clinic, which was in late 2013, we've consistently seen or had over 100 episodes per month and up to 160 episodes per month of patients utilising this service. And this is across all the tumour streams that we currently see at Western Health. And obviously this varies per tumour stream with different patient groups more likely to utilise such a service. But we see education so all patients are receiving their education through this clinic. The red is physical attendance and the green is for phone advice or something being discussed with our CERC nurse. There's a barrage of different symptoms that are the main presenting complaint for the contact with the CERC clinic, with GIT issues or chemotherapy-induced nausea and vomiting, not surprisingly being the predominant. 80% of these, actually over 80% of these are managed over the phone with advice about antiemetics, reassurance and fluid, etc., with clear triage of ongoing review or attendance in the CERC clinic if required. Most patients are calling, so this is regarding the patients that physically attend the clinic. Most patients are calling themselves prior to coming in, although we do see some walking in directly to the clinic. Occasionally GPs, frequently outpatients, and we've moved the unwell on day of chemotherapy treatment to the CERC clinic as much as possible, which can improve our efficiency of our CDU chair utilisation. So if we come back to what happens when you get sick from chemotherapy at the Western at the moment, we've still got all our previous options, but now we have the CERC clinic as well. And what we encourage is for most patients at onset of early symptoms, call to the CERC nurse. Unwell on the day of chemotherapy, CERC nurse. GP, we encourage communication with the CERC nurse or referral to the CERC clinic. Most CERC consults are discussed on the phone and no further action is required, so this is the little old lady. However, if required, the CERC clinic can organise direct admission to the oncology ward and reduce the need for an emergency attendance. And since time of commencement, we've had more than 270 direct admissions to the ward from CERC, and almost all of these patients would otherwise have gone through the emergency department. This was a quality assurance project and these numbers are small, but we do know in the small numbers of patients we have surveyed pre and post intervention that symptoms have been reduced and the patients have reported increasing confidence in managing their chemotherapy related symptoms. 74% of patients would have gone to emergency, phoned or presented to the CDU if CIRC had not existed. Since we commenced CIRC, because now it's been going for a number of years, we've expanded to include oral chemotherapy patients, which has been a successful intervention. In addition, we've implemented a GP communication tool. This means that every patient that attends through CIRC for their chemotherapy education, the CIRC nurse fills a single page. This patient is starting chemotherapy on this date. These are some important side effects to look out for, and this is how to contact us. It's also got a psychosocial tick box of what services we are organising to provide, or could you please help us provide. And we did this because our communication with GPs at commencement of chemotherapy was unbelievably poor when we audited it. We would love, in terms of, in italics there, I've got what I would love to do in the future, but we currently have no capacity, and one is accept referrals from ED triage for patients that would be better managed in the CDU. And we'd love to expand to non-chemotherapy and end-of-life or palliative care patients, so we also would prefer not to attend ED. So in summary, we've developed a well-utilised, safe and sustainable clinic at Western Health with patient and clinician approval. Our patients are more confident with their symptom management, and we've produced an alternative to the emergency department for review of chemotherapy patients. The model of CIRC is currently being adapted and piloted across 4 other Victorian hospitals, and we await the details of this. And thank you for letting me speak again about CIRC, and to all our patients at the Western Health, who they're a difficult group of patients, and there are so many of them that it's good to be able to provide something good for them. Angela and Ilana worked with me initially on the setup of CIRC, and we had a great advisory group at Western Health. Jane has been our CIRC nurse for most of the time, and Juan is our nurse unit manager who's passionate about CIRC continues. Gina, who's at Department of Health and helping us with the piloting elsewhere. Department of Health for our initial funding, and Western Health, and if we talk about culture, Western Health Oncology Service has a culture which allows change and is passionate about quality care. So that's all.
Thanks, Sally. That was really good, fantastic, and good to see it spreading across Melbourne. I did think I saw a CIRC on a previous slide, so it has had a great impact. Questions? You got any questions? So this is a reading test for me, actually. What is the physical structure of the CIRC space?
So it's a separate private room in the chemotherapy day unit, which has bed, computer, what else? Just a separate space in the chemotherapy day unit staffed by a chemotherapy trained nurse who's also been educated in CIRC. It sits next to the chemotherapy day unit, but within the whole chemotherapy day unit space. I think it's really important to have them co-located and for the staff to work across the 2 services.
So what about hours of operation?
So it's 8 till 4, 8 till 3, 8 till 4, 8 till 4, Monday to Friday. We don't have capacity for after hours, and I think that we did audit when our patients were presenting to ED. I think if they're sick enough to need after hours care, then they still need after hours care. Yeah. But if they're not sick enough, then hopefully they can wait or, call within the hours of the service.
I seem to remember Peter Mack, and when I was there, trialled at least a way of getting urgent admissions into the ward at night. So you could extend this into the ward environment to cover the night hours if you really...
Yeah, so we have safety concerns because we also see urgent cases in our CIRC, and we do lots of quality assurance projects through CIRC. So febrile neutropenia we're doing at the moment, and I think we'll find the data is that we're actually managing it much better through the chemotherapy day unit rather than the emergency department, but I'll await this data.
Okay, thanks Sally, we better move on.